This is the New York City Department of Health and Mental Hygiene's update on COVID-19 for New York City healthcare providers. Please note that you have all been placed in listen-only mode. If you have any questions during the presentation, please submit them via the Q&A portion of the WebEx, and we will address them as time allows. As a reminder, a PDF of these slides, as well as a recording of today's webinar, will be available on our website following today's presentation. We appreciate you taking your time to join us today. And I will hand it over to Dr. Marjorie D. Ray.
Hi, everyone. Welcome back to our provider webinar. There we go. So today we're going to hit some of the same old highlights that we do every week, but we have a couple special guest stars, as Allison mentioned. So I'll start with a very brief where are we now, and today the surveillance and epidemiology update is going to be given in a more interactive way by our epi data lead. Then I'll come back and give you a little clinical update on obesity and COVID-19. And then we have Dr. Miller from Health and Hospitals talking about hoteling resources for patients and contacts as a follow-up to last week's excellent talk by Dr. Vora on the testing and tracing operations. So worldwide, we are at over 7.2 million cases and over 400,000 deaths. New daily case count records are being set all over. So, and this is a trend where we'll talk about the New York City data in a moment, but you are seeing some places where cases are going down and some places where cases are rapidly rising, and that can actually change from week to week. So it's really hard to pin down an overall trend around the disease. And I think, I'd encourage everybody to look at the data themselves, as you'll see from Dr. Thompson's excellent presentation. It also, when we talk about our clinical guidance that's on our website, I just really want to highlight how important it is to adapt your behavior to the local risk of the disease, because the risk of the disease in New York City might not be the same as it is other places in the United States, other places within New York State. Also, we're seeing large-scale protests against racism and police violence across the United States, including in New York City. And we have some guidance around protests that'll be coming up later in the presentation. And of course, in other news, New York City, 100 days after its first recognized case, began initial stages of reopening on Monday. And as we've discussed in this webinar before, reopening is something that we have to do cautiously, gradually, and in phases. And so things like wearing face coverings are still critically important, and perhaps even more important now. All of the measures that we've really talked about on this webinar, including the hand washing, etc. So now for the data. So we are coming up on 7.5 million cases worldwide, and we've exceeded 400 deaths. This is just a map of case distribution by country, and the darker the color, as you can see in the legend, the higher the case count. And you can see the US, Brazil, and Russia are darker than the other areas on the map. This is an interesting map where we actually look at the change over the last 2 weeks in the number of cases, and this will give us, the previous map looked at the cumulative number of cases since the pandemic began. This map shows us what's happening in the last couple of weeks. Red is quickly rising cases, blue, the cases are falling, and this is again on the level of each country. Now, if we drill down to the United States, we have the cumulative cases and deaths. As you can see, our area is, as usual, the biggest and darkest circle. But our share in the United States of global cases and deaths is a little bit lower than it was last week and the week before. So we have exceeded 2 million cases in the United States, and we've exceeded 100,000 deaths. But these both represent about 27 to 28% of the global cases and deaths. A couple weeks ago, it was about 30%. So the number, there's a small change in that number. And this is similar to that global map. So by county level within the United States, this is just what's happening in the past 2 weeks. And contrary to the bigger map, or the previous map I showed you, which was cumulative cases, our area is not amongst the red area of the map. And so locally here, cases are falling or about the same within New York. But you can see in areas of the South and the West that there is a large increase in cases over the past 2 weeks. And now I am going to introduce Dr. Thompson, who is going to talk to you a little bit about data.
Okay, good afternoon, everyone. Thank you, Dr. Ray. As mentioned, my name is Corinne Thompson. I'm one of the co-leads of the Epidemiology Data Unit here at the New York City Health Department. And I'm very proud today to be able to present to you a lot of our data here that we have put on our website. My goal today is to go over some of the EPI with you here on the webpage, but also to teach you a little bit about how to use the webpage. We've tried to design it to be interactive and easy to use for the public. And just also to note that all of this information I'm going to show you is available for download. And we're very proud of that. We would love for our data to be used not only by the public to understand what's going on and by clinicians to inform their actions, but also by academics and others to try to understand, answer one of the many questions that we still have about COVID. So just to orient you, we have a couple of tabs here. At the top, we have a summary page, which I'll spend most time on. But we also have a death page specifically related to both confirmed and probable deaths. And then we have information by boroughs. And then we have 2 other tabs that I will leave you to explore if you are interested. Let me bring up GitHub here. So just to show here, this is where I'll show you this at the end, but this is where you can access our data to download. And then this is where you can see New York City as a whole, what the city is doing in response to COVID. So as Dr. Ray mentioned, we are the biggest and the best here. We have over 200,000 cases in New York City at the moment, 205,000. We have a total of 53,000 known hospitalizations and 17,000, a little over 17,000 confirmed deaths. So that is a person who's passed away who had a positive PCR laboratory test. And then we also have about 5,000 probable deaths. And probably we're one of the only jurisdictions that is reporting this count, and probable death is someone who has passed away of COVID-like illness, but had either a negative test or no PCR positive test. And we do update this every day, including on weekends. So the first thing here is just our epi curves. We have cases, most of the information broken down is by cases, hospitalizations, and deaths. So just to say, this is cases by date of diagnosis. So you can scroll over and see each day's value on the top. And one of the notable features of our data and data from elsewhere is we definitely see a dip in the weekend diagnoses. So people don't, same in peacetime, people don't typically go to the doctor as often on weekends, and also clinics are closed. So we see this very routine dip. And then we have our hospitalization epi curve. We can see we're at about 30 to 50. This is by date of admission. So this is new hospitalizations by date of admission. We're definitely, the peak of the epidemic was the last week of March, first week of April, and we've definitely declined since then. And then this is the epi curve of deaths. The peak for this is confirmed deaths only. The peak is the second week of April here. So there was a bit of a delay between unsurprisingly, between the peak of the epidemic in terms of cases and deaths. But we are still getting roughly 30 deaths a day. This is again by date of death. So one of the features, as you are aware of surveillance data, is there is always a lag. So between when somebody starts to feel sick, when they get a specimen taken, and when we hear about it. So often a lot of our data is what is called backfilled. So this information here is incomplete. So that it depends on the testing volume. The turnaround times are now about 3 days from when specimen collection date to when we hear about a positive test. So just to keep in mind, any recent data on this webpage is likely to be backfilled. Although with deaths, sometimes it can take up to two weeks or so for us to hear, to be notified of a death. And then another feature that we find is very popular is our maps. So we have 5 different maps here. This is cumulative data. We do recognize that people are very interested in knowing what's happening now. So keep your eyes out. We have, hopefully in a couple of weeks, we'll be able to have another tab up here that will be called recent. So we'll have information that reflects the last 4 weeks only, as we realize that cumulative data, unfortunately, this outbreak has been going on for long enough that cumulative data is no longer particularly relevant, especially if you're trying to make decisions for how to advise your patients in terms of what they should do. But just to say, this is by zip code, and the darker the color here, it's the higher the case rate overall since the beginning of March. And one of the nice features is you can scroll over and see all of the information. So not only the zip code in terms of its number, but also the name. You can see the case count there, the rate per 100,000, and then the percent positivity, which I'll talk about in a moment, as well as the number of confirmed deaths and the death rate. So we can see very clearly here that there are several areas that are consistently dark. We have Corona, Elmhurst, Flushing here. This has been an area of concern since the beginning. And we also see higher case rates in the Bronx, especially in the northeastern Bronx. We've recently started to see quite a lot of testing going on in Fieldston up here and Riverdale in the northwest Bronx, which is leading to higher case rates. But just to say, especially in the beginning, one of the reasons we were not so fond of just looking at case rates is access to testing issues. So we started to look at percent positivity as a way of getting around some of the testing biases we saw in case rates. So for example, it's conceivably easier that people in parts of wealthier areas of the city have an easier time of getting a test. So that's why we started to look at percent positivity, which is not necessarily the easiest thing for the public to understand, but hopefully the more we talk about it in clear language, the better people feel about it. So this is the numerator here is the number of people who've tested positive, and then the denominator is all people who have gotten a test. So if the color is darker, it's hopefully reflecting a potentially more concerning area in terms of recent transmission or incidents. And it gets around access to testing issues to some extent. And then also just to show we have death rates as well. This is rate of death per 100,000. We are working now to try to pull out congregate setting information because we do recognize that there are congregate settings, long-term care facilities can cluster in different neighborhoods. So keep that in mind when you're looking at some of these maps. And then we also have counts. So we know that counts are often easier to understand. So we have these proportional symbols here by count. So we have case count, and then death count. Again, this is cumulative. Okay. Also, something that is very popular here is what we call syndromic surveillance. This is emergency department data from 53 emergency departments around the city. This is kind of like our early warning system. It's messy, but it's fast. So if we were to see an increase, for example, related to the demonstrations or when our second wave, because it's a question of when, not if, when our second wave starts to arrive, we'll be able to see it here first. So we have visits here. So this is ED visits for COVID-like illness. And then we also have admits. So ED admits by age. This is rate of ED admits by age. So you can scroll over and see each individual data point by age. And then the dark line here is the overall rate. So you can see we're doing pretty well. We're still very low, which is good. And then you can see the residual flu season here. So we really started to take off the first or second week. Someone's calling. Should I keep going? Okay, keep going. All right. And then one of the last things here is I'll say is we have testing information. So this is PCR positivity only. We will eventually hopefully put serology data up here too, but we have PCR. This is percent positivity over time, and the mayor has been using this, and we've been tracking this as a way to understand and to communicate where we're at in terms of the phase of the epidemic. So we're at 3% for a while. Our peak was around 70% back in late March. And we also have the number of people tested over time. So the dark blue line is the number, the count of people tested every day. And then the light blue line is the number of people who are testing positive. You can see a really dramatic increase in the number of people tested over time. Also something to note is that in the beginning, due to resource issues that you guys are very well aware of, we were recommending only for people who are hospitalized to get testing. So a lot of the data, especially in the beginning, relates only to severe cases. As most, we were encouraging mild and moderately ill people to stay home to preserve PPE and to preserve testing supplies. So that is why we've seen a really dramatic increase since then. And then just also to say we have some demographic breakdowns that you can take a deep look at. We also can, again, download this data by cases, hospitalizations, and deaths. So we're showing rates here. So the first one is age. So you can see very clearly, well, you can see that the rate among adults is actually roughly similar. You see it over the age of 45. You can see not too much variation. But when you start to look at hospitalizations and deaths, you can really see the rate among 75 years and older, about 2,700 per 100,000. You can see a very the increasing age, increasing hospitalization rate, and then even more clearly increasing age and increasing death rate. So with 1,500 per 100,000 75-year-olds, death rate is pretty staggering. We're also seeing, which is no surprise, this has been consistent with what's been seen globally, is higher rates of cases, hospitalizations, and deaths among men. Unclear why. We're also very proud to be trying very hard to get good and race, or at least complete race and ethnicity information. So we have cases, hospitalizations, and deaths for the 4 major race and ethnicity groups. Unfortunately, as you get more severe, you can see the disparities become pretty horrendous. So Hispanic, Latino, and Black African American twice as likely to die of COVID compared to white and Asian Pacific Islanders. We also look at poverty. We neighborhood level poverty. So we have low poverty neighborhoods compared to high poverty neighborhoods. And you can see as we move from cases, hospitalizations to deaths, you can see it gets pretty dramatic. So the rate among low poverty neighborhoods compared to the rate among high poverty neighborhoods is over double. Excuse me, reverse that is under half. Okay, and then we also have borough. So now I think my time's almost up, but I do want to just show you. So we have information here on deaths that you can explore. This is the darker, this is an epi curve here. We're showing confirmed and probable deaths here in this epi curve. You can see a lot more probables early on. And then this is something we're trying to take a closer look at disparities here. So we're looking at confirmed death rates by 100,000 by race and also age. And you can see here, again, the rates among Hispanic, Latino, and Black African American New Yorkers much, much higher, especially in these older age groups compared to white and Asian Pacific Islanders. And then borough, again, the Bronx, not surprisingly, although very unfortunately, consistently very high death rates, especially among the elderly here. And then also just to say we have some information on underlying conditions. We are trying to break it out to understand more about the prevalence of each specific underlying condition, but that data is very messy. So it will take us some time. And before I go, just to say, on GitHub here is where our data repository, this is where everything is stored. So at any point, if you are interested, you can come and download. This is the borough. So we have for each borough, this is the information that we display in graphic form, but we have the rates here and then the counts. And then again, this is updated every day. So we encourage everyone to come and download this data and use it. And keep your eyes out. We are trying to update again with more recent information and then also hopefully some serology data as well. So thank you very much.
Thank you so much, Dr. Thompson, for that excellent presentation. Now we'll have a really quick clinical update. So we just heard and saw from Dr. Thompson that age is a really, really significant risk factor for severe COVID disease. And you know, like as you saw in the graphs about hospitalization and about deaths, for sick patients, as people get older, it seems like the risk increased. A pattern, however, that we saw in New York City was a little bit different. And if you look at that data, the sick patients, there were very, very few younger patients in places like the ICU where, or who had very bad disease. And this is a quote here from a physician in New York City who was looking across the ICU and noticed that among the younger patients, there was a pattern of an elevated BMI relative to what they normally see in the ICU. And so this spurred a study. This is a retrospective analysis of 3,615 COVID-19 patients who presented to the ED stratified by both body mass index or BMI and age. And so what we're seeing there is that in this large series, the severity of disease measured by likelihood of admission to the hospital and also admission to the ICU was significantly increased in young patients who were obese. And pay attention as I talk about different studies to what definitions we're using around obesity. In this study, the definition was a BMI over 30, and 30 is traditionally the lowest cutoff to measure obesity for body mass index. This pattern was also seen in larger series. This is a figure from a morbidity and mortality weekly report from April. I believe this was from the early release. I think the figure has been amended slightly in the final release, but the source is down there, and I encourage you to check out the full study. But what you can see is you have underlying diseases here and rates of underlying diseases among hospitalized adults with COVID-19. And you can see that hypertension and obesity are both significant. But if you look at a lot of these patterns, in general, you're seeing that the older patients with the comorbidity are presenting. There's a higher prevalence of older patients with the comorbidities. The pattern is distinctly different with obesity, where actually if you just look at patients 18 to 49 years old, obesity comes out as a very important factor. And so we talked about young patients. So I think this spurred an investigation into whether there's a correlation between obesity and severity of COVID-19 disease in patients of all ages. And here I'm just showing results from, there are several studies around obesity that report about obesity prevalence together with COVID-19 prevalence, but these are a couple studies large studies from New York City. And the first study looks at, so we have two kind of pieces of data here. The first piece is hospitalized. So that looks at one level of severity of disease. And both studies found similar, or all three studies from New York City found similar prevalences, where about a little over a third of all hospitalized COVID-19 patients have a body mass index greater than 30. And then that prevalence is even higher if you look at patients with severe disease measured by the fact that they're on a ventilator. And you'll notice here that the cutoff for measuring obesity is a BMI greater than 30. Now, if you look at mortality, we have a study by Palaiodimas et al. And Palaiodimas and colleagues, and they used a cutoff of BMI greater than or equal to 35, and this was a retrospective cohort study of 200 patients followed for 3 weeks. And of course, we've seen before in these studies that while we want to get information out, some of these patterns can change as we are able to follow patients for a long time. However, the mortality of the total cohort that was obese by their definition was 24%, which is a number that's higher than you'd expect based on baseline prevalence. And so why? why is obesity related, possibly related to severe disease for patients who have COVID-19? And this is an interesting question. As usual, when we talk about these clinical mechanisms, we don't really know the answer, but I'm just going to talk through a couple theories. Obesity and respiratory disease that have a very interesting relationship, and several other pandemic respiratory viruses, especially H1N1, have shown to interact with sort of body homeostatic mechanisms to create a more severe disease picture. And this is well documented in H1N1, and that's a pattern that was brought up as this pattern of severe disease and obesity co-occurring was first noted in COVID. And so I'll just very briefly walk you through a couple of these mechanisms. One is the interesting, like the relationship between adipose tissue in obese patients. And so obese adipose tissue on the cellular level is a little bit different than lean adipose tissue, and this can modulate the immune system. Hypercoagulability, we have discussed before on this webinar how immunomodulation and hypercoagulability are very linked. Some is that there are theories about respiratory dysfunction in obesity, and that's just a purely mechanical respiratory dysfunction, and of course the co-occurrence of comorbidities with obesity. And here we have a diagram just showing that immunomodulation is really about the balance of anti-inflammatory and pro-inflammatory effects, and that this balance can be slightly skewed in obese adipose cells. And this is for both the innate immunity, so that's things like macrophages, neutrophils, etc., and as well as the adaptive immunity, which is the antibody response, which is specific for COVID-19. There's an additional hypothesis that obese adipocytes may act as a reservoir for the virus. So the virus could actually be existing at a low level of replication within adipose cells. And this is based on the idea that obese adipose cells might express more of the ACE2 receptor, which the virus uses for entry into a cell. And then, of course, the fact that there's a well-documented higher occurrence of thrombosis in patients who are obese, and as we know, we know hypercoagulability is a feature of COVID-19, as we've discussed on this talk before, and this may be compounded in patients who are obese. This is a really interesting diagram that talks about different aspects, about different aspects, and these are the sort of less cellular level and more mechanical and whole body homeostasis level issues. But I really encourage you to take a look at this review from Nature Endocrinology. And there's an idea that in patients who have lung disease and also might have for example, increased airway resistance or impaired gas exchange due to the mechanical structure of additional weight on the lungs. This could impact the severity of COVID-19. As we know, as we know, obesity and cardiovascular disease are linked. Obesity and diabetes mellitus are linked, and we know that diabetes particularly has an impact on the severity of COVID-19 disease, and kidney disease as well, which is a feature that we've talked about on this webinar before of COVID-19 disease. And of course, metabolic risks, speaking to comorbidities, but maybe a little bit earlier in the causal chain. But hypertension, we saw that in the earlier diagram as being very well correlated with severe COVID disease. And so all of these, we have a lot of different hypotheses about what might be causing this or might be creating this correlation. I do want to say that with regard to the mechanical theory, I just want to bring your attention to something called the obesity paradox that occurs in non-COVID acute respiratory distress syndrome, where although patients who are obese may be more likely to develop acute respiratory distress syndrome or require a ventilator for it, their outcomes are actually better. And again, we don't know why. We don't know why this is the case, but it's something to consider when you talk about the possible mechanical etiology of this correlation between obesity and severity in COVID-19. I'll talk a little bit also. So while obesity has an impact on COVID-19, COVID-19 is actually on a population level might be having an impact on obesity. And this is something to consider as we look at the whole picture of obesity and COVID-19, especially as we consider a longer term course of this pandemic. So this is just one study. There are a few studies, and I think many of us are experiencing this in our quarantine lives. But this is a study from Italy, and this is a longitudinal study of 41 obese school children. And then they continued to follow these children as they went into quarantine. And of course, as is very reflective of my personal life, I don't know about yours, but quarantine life for these kids included more sugary drinks and potato chips, less physical activity, and more sleep. There's also a correlation between stress and obesity and the stress, the unique and long-term stresses of quarantine. And of course, at the same time, as we're talking about COVID-19 and obesity, we know that stress can also impact the immune system. And so this is a cycle that we should pay attention to. So guidance on obesity and COVID-19. We don't have a lot of detailed guidance. In fact, one of the, if you'll notice, the second paper we've cited on this slide is titled COVID-19 and Obesity, Lack of Clarity, Guidance, and Implications for Care. But there are a few general strategies. So the very important piece of guidance we have is from the CDC, where we say people with severe obesity defined as a body mass index greater than equal to 40 are at risk of severe COVID-19 infection. We pointed earlier to a couple of papers where it looks like this effect might, whatever the cause of this, whatever the mechanism, the effect might be present even in patients who are obese, but their BMI is less than 40. And so in terms of your interactions with patients, it might be advisable to cautiously observe patients even if they do not meet that BMI of 40 cutoff. There's some evidence that cardiopulmonary fitness could have a beneficial impact on COVID-19. And we can balance that with the fact that we saw that people are in general less physically active. And so with your patients where you're concerned, definitely promote physical activity while physically distancing. Balanced nutrition, again, probably not a great idea to make most of your diet those sugary snacks and potato chips. And regular physician contact. So there have been anecdotal reports of patients who are obese, not just in COVID times, but especially in COVID times, being hesitant to reach out to providers because of stigma, not only from others for being seen, but by the providers themselves. And so, I would encourage all of us to make sure that, we're really considering the outcomes of our patients in the way we treat them. And then, of course, the use of telemedicine, even if it is difficult for a patient to get to your office, there may be other ways to interact with patients. And of course, watch out for the stress levels of your patients. And I think with that, I will give it over to Dr. Miller.
All right, can you all hear me okay?
Yes, thank you.
Okay, so thank you very much. My name is Aaron Miller. I'm Assistant Vice President for Child Abuse Prevention and Treatment at New York City Health and Hospitals. And during COVID, I'm a community partner liaison focusing on hotels and educating people on exactly how the hotels work. You all have patients who you have built trust with. They follow your advice, and we want to explain everything about how the hotels work so that you can decide if this is a good fit for your patient and that you can be the advocate to help get them into our hotels. So in the interest of time, I want to skip a few slides ahead. If you want to go, if you could go ahead and advance the slides. We all know the basic tenets of test, trace, and take care. Next slide. All right, and next slide. All right, so you can go back one. So the take care portion involves two things: take care at home, and if the person feels that they cannot safely separate at home, that we would love for them to come stay at a hotel for 2 weeks. So if you're going to stay at home for 2 weeks and not leave your home, you're going to need some support. You're going to need wraparound services. And so Health and Hospitals is partnered with the Mayor's Office of Housing Recovery Operations to lead resource navigator operations. So I'm going to explain very briefly what resource navigators are. And so HRO is contracted with a host of community-based organizations to hire 200 to 300 resource navigators. And so these are the ones who will sit down over the phone with New Yorkers to really ask them what they need as far as food and mental health resources and medication delivery. Next slide. So how do you get to a resource navigator? So it's the contact tracer who's calling you first, right? They're calling the cases and the contacts. And besides asking about contacts and symptoms, they're going to screen for basic needs of food, medical care, and medication delivery. If the case or contact says they need help with any of those, the tracer will refer them to a resource navigator who calls them back within 24 hours to have this conversation and to really hold their hand in plugging them into all of these services. Next slide. So this is a very busy slide, so I'll keep it quick. In the orange box is what the city is setting up for resources. The Get Food NYC, working with pharmacies to deliver the medications at home. But then each of the community-based organizations who we've contracted with, they already do social service work. So they have their own list in these blue boxes of all sorts of services that they help clients plug into. So orange box on the left is the basic core set of services that we offer right now. But the community-based organizations who are actually serving as the resource navigators are then also offering up a wide range of services that they have. Next slide. The middle column and the right column are the list of the community-based organizations that are serving as the resource navigators at this point. So I'll have this for your reference, and we'll go ahead to the next slide. So the goals of the hotel program are to reduce the spread of COVID within homes, and in doing so, reduce spread among the community. So you get a free hotel room for 2 weeks. And this is not only for people with COVID, but any contacts. And that contact does not need to have been tested to be able to qualify for a hotel. Next slide. So I'm going to talk about how you refer a patient to a hotel, but first, what is going to be the guest experience? When they come, they're going to meet with a social worker to see what they need, both what they need in the hotel to be able to have a successful 2 weeks, but also what they need upon discharge for services going back home. Our community care is the branch of Health and Hospitals that does health homes. So they have nurses and doctors who do home health care who are running these hotels. So a social worker from our community care health home will meet with each guest to see if they qualify for a health home. If you're already a member of a health home, great. We want you to help transfer whatever those services are to the hotel so they can be sure to get those services. And I'll go more into that in a minute for continuity of care. But if they are not a part of a health home and they qualify for one, we will get them signed up for a health home. If they don't qualify for a health home, they will meet with a separate social worker who's just going to help them with the same wide range of getting plugged into services. They're going to get 3 free meals a day delivered to their room, Wi-Fi, air conditioning. If you have kids that you can't leave your home because you have kids with you, those kids can come stay with you in the hotel. There are regular wellness checks where our wellness coordinators come and knock on your door and just look in to see how you're doing, to make sure you're doing okay. Because we know isolation can be tough and it can be dangerous for some people. There's access to video televisits and psychiatry. If they need a psychiatrist and don't have access to one, the psychiatrist can actually come on site, but a lot of the visits that they do are televisits. There's 24-hour nursing on site and on every floor. So people can just poke their head out the door if they're having an issue. But again, we're checking in on them regularly. We've arranged to have people's medications delivered to the hotels, and we provide free transportation to the hotel and back home when they leave. I'm going to have a slide later on continuity of care, but go ahead and go to the next slide. What we expect the guests to bring is a photo identification, if they have any, 14-day supply of medications. If they are on medication-assisted treatment or on methadone, they can bring that to the hotel. We do not provide Tylenol or over-the-counter medications as of today, but that's something that we are working on. No alcohol or recreational drugs are allowed in the hotel. If you smoke, we will escort you out for a brief smoke break. But otherwise, you're not allowed to leave your hotel room during your entire stay. We realize that that is a definite limitation for people. A lot of people who will just get stir crazy. I mean, who among us doesn't staying in one place for too long? But you can imagine all of the infection control issues of having people wandering through a hotel. So to keep people safe, we're requiring that they stay in the hotel the full time. And of course, they need to bring any other comfort items that they have. Next slide. Maintaining continuity of care, we want to be able to continue forward any plans that you have for this patient. So as a referring agency, we expect you to continue providing whatever care, be it follow-up phone calls or televisits or in-person visits in the hotel, as if the client were still at home or whatever setting they were in. If the client has home care services, we'd like to coordinate with you to transfer that care to the hotel while they're there. And the home health aide can, if needed, come stay at the hotel too, or they can just come visit. Guests will receive clinical supportive services while in the hotel, but they will be instructed to follow up with their primary care provider for most medical questions. But again, if they're going to get temperature checks twice a day from our nursing staff, and when something urgent comes up, those nurses are right there on that hotel floor for them. You, the referring agency, are welcome to do a visit for your client at the hotel, but you would need to bring your own PPE and proof of malpractice or indemnity. And guests do receive guidance to call 911 if they're having an emergency, but our on-site staff are available on each floor to help them too. Next slide. Key points regarding youth and anyone who struggles with isolation. Youth under age 18 can only be admitted to the hotel if they have a legal guardian who also comes to stay with them. The client needs to be comfortable staying in the room 24/7. They need to be comfortable with having someone come in and check in on them regularly. And if someone self-discharges from the hotel, we do not call the police. Someone asked me that question, and the answer is definitely no. We do not let the person come back into the hotel, but they could be re-referred through whatever pathway they initially got to the hotel. Next slide. How long are they going to stay there? People who have possible or confirmed COVID are ready to check out when all of the following are true. 10 days after symptom onset, 3 days of no fever without medication, and their illness is improved. Guests who are in the hotel just for quarantine due to contact are ready to check out when it's been up to 14 days since that contact, or if their home circumstances have changed such that they can now safely self-separate at home. Next slide. So referral process, there's 2 ways to refer your patients to the hotel system. You can send an email to comcarecp@nychhc.org. It'll be reviewed by a nurse, and they will respond within about an hour. Include the client's, it's a very basic email, name, date of birth, telephone, and your phone number. If they have medical issues that need attention during that hotel stay, make sure you do 2 things. One, that this email that you're sending, you're using an encrypted email system because it's PHI. And number 2, that you have obtained written consent to share this information with us. You don't have to fax us that written consent, but we will assume that you have obtained that consent. Instead of sending an email, you can instead choose to call the COVID hotline, 844-NYC for NYC. Just say that you need a hotel because you and or your patient have COVID or were a contact of COVID, and you will then be speaking with a nurse practitioner or a doctor who will begin the screening process. At this point, as of today, that is 1 step longer because that person will take your information and then they are going to forward it to the ComCare email. So this is more the number we give to the general public to call. We're hoping to smooth this process to make it fewer steps as possible. So for you as a provider, the most direct route is to send an email to the comcarecp@nychhc.org. Next slide. And again, they'll contact you within about an hour. And then when we arrange for transportation, it takes about an hour or 2 for the transportation to come to your home to pick them up and take them to the hotel. We do transfers to the hotel anytime from 8 a.m. to 9 p.m., 7 days a week. Next slide. And then here, these last 2 slides, this is really quick, just more for your reference. These are a couple prompts we offer you to and encourage you to say to all of your patients to help engage them in each of the test, trace, and take care components. So for testing, say, you have your own method for getting people on board, but so you can change this as you like, but you should get tested even if you feel fine. It's important for all New Yorkers to know if you have the infection or not, and it's a really thoughtful way to keep your family safe and healthy. If you test positive for COVID, you'll get a call from our clinic and a call from a contact tracer. Please answer your calls even if you don't recognize the number and check your voicemails. The contact tracer will help you figure out a plan to stay inside safely, separated from other people, either in your home or in a free hotel, so that you can help protect them from getting COVID. And they don't share this information with police. Next slide. For hotels, it's so tough to wash your hands in every door handle and countertop. You should stay in a hotel for 2 weeks. It's a great way to help keep your family safe. The hotel rooms are really nice. Get 3 free meals a day, air conditioning, free Wi-Fi, and cable TV. And I'll help make sure we transfer all your home care services to the hotel. Your kids can stay with you, and there's a social worker to help also. Next slide. All right, these last couple slides are more for community-based organizations, but they're also for you. We really want to get out to message that there's free COVID testing for everyone and that all New Yorkers should get tested. You're going to get a call from a contact tracer if you're positive, and there's free resources. Next slide. There's lots of ways that you can help out. If there's ways that you want to help out, click on that link there. That's from Department of Health. Next slide. If you are good at tweeting, click on each of those links and that will bring up that tweet on your screen so that you can tweet this across the Twitter sphere. Next slide. All right, that's the end. I'll stop there, and I'm happy to take any questions about hotels and I guess questions about other parts of the presentation.
All right, thank you very much, Dr. Miller. We do have a question for you from the group. Will the hotels be accessible by foster families?
Yes. Yeah, anyone who needs a hotel, they can bring their foster child with them.
Thank you very much. I'm going to hand it back to Dr. Ray.
Thank you so much, Dr. Miller. I just wanted to, we have a slide I promised you earlier in the talk that we would talk about protesting safely. We recognize at the health department that there are two concurrent public health crises occurring. And so, although our guidance does remain to stay at home when you can, we recognize the importance of protests and that many New Yorkers are going to be participating in protests. And so I just wanted to share our excellent how to protest so safely during the COVID-19 pandemic guidance. Some of this is specific to COVID-19, for example, wearing a face covering. And, you might want to note, we're recommending not to yell, which is different than protests people might have participated in before, and this is to limit spread of droplets. Some of the guidance is not necessarily specific to COVID, but is certainly, it represents the fact that, again, we have two crises going on at the same time. And so wearing eye protection to prevent injury is very important, as well as staying hydrated. So please check that out on our website. The link is here. I also want to remind everyone that this webinar, a recording of this webinar, as well as the slides from the webinar, will be posted on our website on the provider section, probably Monday, late afternoon or evening.
Or sooner. We're working on getting it posted over the weekend. We have heard that people would like to have them sooner, and we really appreciate that feedback and understand it. So we do have a few more minutes for questions. I wanted to kick one back to Dr. Ray. It's about obesity and vitamin D deficiency. Obesity has been associated with vitamin D deficiency, and there has been some talk about the vitamin D deficiency in COVID-19 sufferers. If sufferers have a worse outcome related to it, do you know anything about this?
Yeah, so that's a very interesting question, and it's one we get in a lot of different ways about a lot of different conditions. And so, first of all, vitamin D is definitely an immune modulator, and low vitamin D level can certainly impact your ability to fight off disease and the severity of disease if you do catch it. Especially in the Northeast, the prevalence of low vitamin D levels is really high, and especially around this time of year, many New Yorkers have very low vitamin Ds, and so it's hard to correlate. While people who are obese often have low vitamin Ds, there are many groups that have low vitamin Ds, and so it's certainly possible. Another thing that we know is that ICU patients often have extremely low vitamin Ds, lower than you would see in the outside population, and prolonged ICU stays are a huge risk for severe vitamin D deficiency. So, there's a lot of stuff there that's hard to parse out. I would say, the other thing is that vitamin D levels are not necessarily routinely collected in all hospitalized patients. So the data on that are limited. I'd say in terms of what we can do as providers in New York City is definitely pay attention to vitamin D levels. I can't tell you how big the impact on COVID will be if a vitamin D deficient person is returned to a normal level of vitamin D, but I can say it's better for overall health. And so, I think especially given that people have been inside and may have interesting dietary habits, like I talked about during the quarantine, it's probably valuable to check vitamin D levels and to direct patients toward vitamin D supplementation if their vitamin D levels are low.
Great, thank you very much. We have one for Dr. Thompson that I think would be good to address for the group, if possible, just about any update on Miss C with epi curves.
Okay, thank you. So I am not necessarily a Miss C expert, but I can say that the number of newly reported suspect cases, or the number of newly reported children who are meeting or who are under investigation for Miss C has declined pretty significantly over time. So we have 174 cases who now meet the CDC case definition, and we are still investigating a number of others. I can say that we did have a new bolus, not new, but a bolus of cases that were reported to us from New York State that we're working through, but they are not necessarily new in terms of diagnosis date or report date.
Great, thank you. And a follow up on the vitamin D. What are the recommended levels of vitamin D for pediatrics and adults?
I don't know the answer to that question, but I think we can look those up and post those. Sorry, it has been a minute since I have checked a vitamin D level myself.
I think we have one question for Dr. Mary Foote, who's also joining us. Is there any value in having patients with indeterminate antibody test results get retested? And if so, what is the suggested interval?
Hi, sorry, was trying to unmute. So it depends on when they got the indeterminate test done. We generally recommend do not test serology until at least 3 weeks after symptom development, because otherwise you do run the risk for indeterminate or false negative tests, because it takes a while for the IgG antibody response to develop. But if it's been after the 3 week period and it's still indeterminate result, it may be because it's a test with a higher sensitivity but less specificity. So you may want to repeat with another platform, another different type of test that has better sensitivity. That's all.
Great, thank you very much, Dr. Foote. It looks like we don't have many more questions that haven't either been answered in the group here or in the Q&A. So thank you to those of you who have placed your questions there in the chat and for joining us today. You'll see on the screen in front of you that top link, the provider pages, where you'll find a copy of the slides from today, as well as a recording of this webinar and slides and recordings of any previous webinars. Our weekly webinars are on Fridays at 2 p.m. So we hope that you will join us next week. And we thank you again for being here today.